Okay, we are going now to see again with more details this lateral aspect, mostly of the temporal lobe and of the basal forebrain, because it's so important for us in surgery. It's, many tumors and lesions are in this area. Later on today, after lunch, we're going to be talking about the surface, the sulci and gyri. But if we go underneath the subcortical region, if we dissect, this is a white matter dissection as proposed by Klinger. So these brains were frozen before being dissected. And so you know that when you freeze those brains, the water sort of spreads the fibers, so it makes it easier to dissect the fibers. So you can see the U fibers in between the gyri, and you can see the main association fibers of the hemisphere, which is the superior longitudinal fascicle. Now, you know that these names were given by different authors. So somebody called this the superior longitudinal fascicle, and another author did call the arcuate fascicle. But now we are trying to put all this together. But anyway, you have an horizontal part of the superior longitudinal fascicle that goes from underneath the depth of the frontal region, the Broca area in the left hemisphere, towards underneath the supramarginal gyrus. And then you have a vertical part that goes along the vertical aspect of the supramarginal gyrus. And you have a deeper part that goes around the whole thing and project coming more towards the temporal lobe. So you can see here the horizontal, you can see here the vertical, and you can see here a little piece of the more deep one. This deepest one that goes along the whole thing, it's nowadays called the real arcuate fascicle, that has to deal with language, more with language in the left dominant hemisphere. And as you know, this is all being now very well studied through tratography, and they are giving names and they are doing a lot of research in this. And I think that the main concern is just to know what is real and what's not real when you do tratography. But you can see here that you have a horizontal part and you have a vertical part, and you have a deepest part that goes, the red one, that goes along from the frontal region, supramarginal, until the temporal region. And this red part is the what we call nowadays the arcuate fascicle. So the arcuate fascicle is the deepest part of the deepest component of the superior longitudinal fascicle that you can see all together here. But at this point, we did remove the surface of the insula, and we are seeing what we call the extreme capsule, which is nothing more than the subcortical white matter of the insular cortex. Okay, if we remove a little bit more, you can see that it's more dark here, and this would be the gray matter of the claustrum. And we have still left the whole superior longitudinal fascicle here. You see some beautiful U fibers here. If we remove more, we start almost seeing the putamen, but this is the external capsule. You see white fibers here, you see the external capsule. And at the base here, you see that we have, you can already see that we have two different bundles of fibers here. The most anterior one is the uncinate fibers, are the uncinate fascicle, the uncinate fibers of the uncinate fascicle. And they put together the mesiotemporal region together with the frontal orbital region. And more posterior, you have what is called the IFOF, different names. IFOF stands as the inferior occipitofrontal fascicle. Some people just call it occipitofrontal fascicle, but this name is being very popular now, the IFOF, inferior frontal occipital fascicle, I'm sorry. At this point, we did remove the rest of the external capsule. I mean the rest because these two fascicles, they sort of are in the same layer as the external capsule that was removed here. But you can see better, they are more identified. You have the IFOF that it's sending here underneath the inferior frontal gyrus. at its depth in the frontal region, and you see the uncinate fascicle that it's going more towards the frontal orbital region. Uncinate fascicle, IFOF. And of course, if you did remove the external capsule, you start seeing the putamen, and you see that there are some fibers that are getting inside the putamen. I didn't talk about these fibers yet. They are the cortical striatal fibers, and they belong only to the corona radiata or centrosemiovalle because they don't belong to the internal capsule, because they get inside the striatum, inside the putamen, and inside the caudate nucleus when they are more medially, okay? So they don't belong to this concept of internal capsule. That is just the fibers that are below the superior margin of the putamen. But you're seeing here beautiful cortical striatal fibers getting inside the putamen, okay? And at this point, we did cut the vertical part of the superior longitudinal fascicle, and we're seeing all these fibers here, okay, that you see that the uncinate fascicle gets intermingled, gets together with all these lateral fibers. You see that the IFOF is continuous here, you know, coming from the occipital until the frontal region. This is called the inferior frontal occipital fascicle, but maybe the best name would be occipitofrontal fascicle, okay? That's how Touré call it. But you see there are two different bundle of fibers here. At this point, we did remove the putamen, and you're seeing the internal capsule fibers. This is the globus pallidus, that it's more white, more medial, to the more medial and more inferior in relation to the putamen that was removed here. And again, we are seeing all these fibers that are covering the inferior horn and the atrium here. And I already said that these fibers are referred to be as being called the sagittal stratum. This name was given by Joseph Klinger. He's the one make it popular. I don't know if he was the one that coined the name. Again, sagittal stratum covering, so it's the roof and part of the lateral wall of the inferior horn that is underneath here. And I'm already seeing the anterior horn, I'm already seeing the choroid plexus, and I'm seeing a bulging inside the choroid, the inferior horn. So what is this here? What is this? It's something inside the medial aspect of the temporal horn, the temporal lobe, inside the ventricle. What is this? Can be only one structure. This is the head of hippocampus. This is the head of hippocampus. I would say that this is just anterior. Here is the amygdala, because the amygdala is anterior. We're starting to see the amygdala because the amygdala is anterior to the head of hippocampus. So you look at this, you have to know that you are the head of hippocampus. Uncinate fascicle, IFOF, globus pallidus, internal capsule. If we dissect a little bit more, we're seeing a bundle of fibers that is just anterior, running anterior to the globus pallidus. Again, you have to know that everything that runs anterior along the base of the globus pallidus is the anterior commissure. So you're seeing that the anterior commissure are fibers that they will be coming here, but they are inferior to this superficial fibers of the sagittal stratum. We're going to be seeing that the anterior commissure fibers also belong to the sagittal stratum. Of course, try to have in mind that these are concepts. When I say internal capsule, this is a concept. When I say centrosemiovalle, this is a concept. When I say sagittal stratum, is a concept. Some fibers belong both to the internal capsule and to the sagittal stratum. Okay? The fibers of the internal capsule are the same that come from corona radiata. So these are concepts, okay? These are fibers that are put together and for us to have a group of fibers. If we see more close, we see the globus pallidus, we see the anterior commissure, okay? And I see here some gray matter. This gray matter has to be the ventral striatum. This gray matter is a striatum. I'm in the base, so I'm in the ventral striatum. When I talk ventral striatum, is synonym of accumbens. So this is accumbens. And I'm seeing that the floor here, which is the anterior wall as well, is all perforated. Can anybody tell me what is this? If it's perforated, it's because I have things coming through here. What is this? What structure is this? What do you have here in the base where you have the bifurcation of the carotid artery, and you have perforators coming through here that go to the tano capsule, to the basal ganglia? What wall do they go through? The anterior perforate substance. You know, if you know it, it's there. You have to name it, okay? Anterior perforate substance. So I want to emphasize that we are seeing a region here. We see a region that has as its floor the anterior perforate substance. Anterior wall would also be anterior perforate substance. Posterior wall would be the anterior commissure, the globus pallidus itself. Medially, we have the accumbens. The accumbens indeed is inside this region here, okay? The roof of this region would be the anterior limb of the capsule, mostly, okay? This area here is referred to as being the ventral striatum. The right name would be ventral pallidostriatum, because you have the anterior part of the pallidum also belonging to this region. The ventral part of the globus pallidus was called in the past, was known in the past as the substantia nominata of the German literature, because they didn't know exactly what was going on. They called a place with no name, substantia nominata, substance with no name. So the substantia nominata is a name that it's within this ventral striatum region. Some other people call this area here the anterior perforate substance area. Michael Lawton has some beautiful paper about cavernomas in this deep cavernomas, and he referred to this region as being the anterior perforated region, which is also a good name. Anatomists like Leonard Heimer, that had studied very much this region, he called it ventral striatum region. But this is an important region for us for many things, particularly because insular gliomas, they would come along the temporal stem that we're going to be talking about, this area here. The insular gliomas will be coming here through the ventral striatum, and ventral striatum is a corridor that will end deeply and medially into the septal area. And so tumors go along here. And this is an area we cannot get in there microsurgically yet. I don't know if in the future, but why? Because you have the lenticulostriate arteries and you have so many important structures here. You have the minor nucleus here also, the cholinergic nucleus that has to deal with Alzheimer also. You have the anterior limb of the capsule is a target from some DBS procedures, and this can be talked by others later on. So we have really to understand this area nowadays. And laterally, you have, of course, what we talked about already, the IFOF, and you have the uncinate fascicle anteriorly here. If we remove the IFOF and the anterior uncinate fascicle, let me come back here to emphasize this. Next slide, I'm going to remove this IFOF. I'm going to remove the uncinate fascicle. And when I say I'm removing it, I'm not removing it here. I'm peeling the fibers from the sagittal stratum. These fibers are the most superficial fibers of the sagittal stratum. I'm going to remove this and to remove all these fibers here. And when I do this, I expose the anterior commissure. And you see that the anterior commissure has its fibers also going posteriorly. Let me see, what's the next slide? You see here the anterior commissure, and you see that you have anterior commissure fibers here going posteriorly. This is still sagittal stratum, is covering the inferior horn and the atrium as well. The atrium will be here, okay? So superior to this, I'm sorry I'm repeating this much, but I want you to have this in your memory. I did remove the uncinate fascicle that was here and the IFOF that was superficial to the anterior commissure fibers. And you see that the anterior commissure fibers, they are running in a groove that is within the anterior aspect of the globus pallidus. Now, let's see what we have underneath here. What is this here? I already showed a few slides ago. What is this?
Amygdala.
Pardon?
Amygdala.
No. Posterior. This is the inside the uncus. This is the posterior part. This is the head of hippocampus. If this is the head of hippocampus, what is this here? This is the amygdala. And what is this here? You see that this is a ventral extension of the amygdala? This is the ansa peduncularis. Ansa peduncularis has three components. It's the fibers that are leaving the amygdala and going medially, okay? One component is the fibers that are going to hypothalamus, to the thalamus, and to the septal region. Ansa peduncularis, hypothalamus, thalamus, and septal region. All together, they constitute the ansa peduncularis. Okay, all together they constitute the ansa peduncularis. Of course, down here you have the optic nerve, and you have the optic tract. You have the the pituitary stalk here. You have the mammillary bodies posterior there, and you have the interpeduncular fossa. You have the third nerve. This is already pons. This is the basilar impression. Okay, this is the fifth nerve coming laterally. All right. So, but let's focus again here: anterior commissure, ansa peduncularis. In this next slide, I'm lifting the anterior commissure, and you see that the anterior commissure fibers go posterior. They go a little bit anterior, but they go posterior as well. And what did I do now? I did cut the anterior commissure fibers and did remove the anterior commissure fibers that I had here. You see the anterior commissure? I'm going to cut here, and I'm going to peel all these fibers to show that this is all sagittal stratum. We are, I would say, at the mid-level of the sagittal stratum now. But if I peel this, I take this, I just leave this more anterior part and medial part of the anterior commissure. I see that I left fibers that are arising here posterior to the globus pallidus. They are going more anterior, and then they go posterior. Okay? Can anybody tell me what fibers you think are this? This is our more deeper fibers of the sagittal stratum. What fibers arise at this region here, go anterior, and then go posterior towards the occipital region? This is the Meyer lobe. This is the optic radiation fibers. You see? So remember that the superior aspect of the sagittal stratum was the IFOF. Okay? Then I have anterior commissure fibers, and underneath I have now the optic radiation. And you see that the anterior commissure is always inside this channel here, this groove, that it's called channel of Gratiolet. Channel of Gratiolet. Again, what is this here? Very anterior. Amygdala, ansa peduncularis. Ansa peduncularis. Okay? Fibers that are going to the hypothalamus, to the thalamus, and to the septal region in the midline here. This is optic tract. Okay? Amygdala, this is globus pallidus. What is this here? This is internal capsule. So this is anterior limb of the internal capsule. So what gray matter is this? Yeah, don't be afraid. What is that? The head of caudate, of course. If this is anterior limb is between the head of the caudate and the putamen that was removed here, okay? So this is the head of the caudate. This is striatum, head of the caudate. So, and what is this down here? Same thing, but it has another name. What is it? The accumbens, the ventral striatum, the accumbens, okay? Now, I did bring this anterior commissure here for you to see more the channel of Gratiolet. Any brain you will find it. Very deep, very old phylogenetically, anatomically very constant. I said this is globus pallidus, and this is amygdala. You said, look, remember what I told you about? That superiorly, the amygdala is continuous with the globus pallidus. This is Richard's dissection. I never saw a dissection like this, never saw it. I read it, you read, but you never see that the amygdala is continuous with the globus pallidus. And remember that The tail of the caudate will be coming here underneath everything as the roof of the inferior horn. This is the hippocampus is floor of the inferior horn. The tail of the caudate will be coming here underneath as the medial part of the roof of the inferior horn, and will also end in this complex here of the amygdala coming into the globus pallidus. And this is the accumbens. Here you have another view of this, but you see this is optic radiation mostly already. As Ture, Ugur Ture from Istanbul is one of our greatest neurosurgeons in the world now for tumors and many other complex things. And he's, I would say that he's the one that understands mostly about white matter dissection and fiber dissection. And he always say that you cannot say this is only optic radiation. You have a lot of other fibers intermingle here, but most of these fibers are optic radiation because we did remove most of the fibers of the anterior commissure and of the IFOF that were superior to this. But you have here the caudate that you did recognize, the accumbens, internal capsule here, the globus pallidus, and I'm showing the same thing for you to keep in mind this three-dimensional architecture of this important region here. You see, this would be the septal region in the other side, so this is where the ansa peduncularis would end in this side. Now we're seeing from below, and you're seeing that this is the anterior commissure, and you're seeing that this is the Meyer loop. I'm sorry, this is the anterior commissure, and you're seeing that these fibers here, they are arising from this posterior aspect of the thalamus. Let's just remember, you see here midbrain, substantia nigra, okay? This is the lateral mesencephalic sulcus. This is pulvinar. This is, of course, this is thalamus. Lateral mesencephalic sulcus, remember that I told you that always has superior the medial geniculate body. Always, 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 okay? Always. And then this is medial geniculate body, and the lateral geniculate body is more lateral and more anterior. And it's, of course, pretty much already related with the roof of the inferior horn. And you see that this optic radiation fibers, they don't come only from the lateral geniculate body. They come from the whole pulvinar, the whole posterior part of the thalamus. This was a paper we published with Richard, as first author. He did about the optic radiation, and it was published with 3D images, and emphasizing that they don't arise only from the lateral geniculate body. And the old anatomist, it's unbelievable how the very old anatomist had described everything already. You know, they used to call the posterior aspect of the thalamus that we call pulvinar, they used to call optic thalamus. Because Gratiolet, in the middle of 1850, more or less, 1860, 1840, he had described the optic radiation. And he was the one that related these fibers that coming from the posterior aspect of the thalamus, and that's why they called this part the optic thalamus, because optic radiation fibers were arising from all over here. This is perforated because you have perforators coming here. This is the posterior perforate substance area. Everything that is posterior to the optic tract is posterior perforate substance. Everything that is anterior to the optic tract is anterior perforate substance. We'll come back to this in another slide. But this is posterior perforate substance that it's posterior to the optic tract and gets, of course, not only at the base of the third ventricle in the hypothalamus, but gets also inside the interpeduncular fossa. The roof of the interpeduncular fossa also is posterior perforate substance. This is an animation Richard did of the optic radiation, okay? So you have more anterior fibers that constitute the Meyer loop itself, okay? And they go to the inferior margin of the calcaneal fissure. Remember that the calcaneal fissure is a fissure that there is in between the lingual gyrus and the cuneus. We'll come back to this later on today, but these fibers go to the inferior margin. And then you have middle fibers that they don't reach the calcaneal fissure. They end at the cortical surface of the occipital lobe, and they are responsible for the macular vision. And then you have more superior ones that are more related with the atrium. You see the atrium here. They cover mostly the atrium, and they go towards the superior margin of the calcaneal fissure, namely to the cuneal aspect of the calcaneal fissure, to the cuneus. Okay, so you see that it's impossible to get to the inferior horn and to the atrium laterally, not damaging the optic radiation. It turns out that if you do a small lesions here surgically, patient will not perceive that he has a very mild visual deficit, but they cover all the ventricle. And let me emphasize that all these fibers are within the so-called sagittal stratum. They are the deepest part of the sagittal stratum. They are covered by the anterior commissure fibers, and they are covered by the IFOF fibers as well. So if you come back to the slide that I showed already, you can understand better now. We have the insular surface. We have the extreme capsule with the calostrum. We have the external capsule. External capsule, same layer that you have the IFOF and the uncinate fascicle, okay? And then you have, of course, the putamen underneath, right? And all these fibers all together, they are the sagittal stratum. The most superficial ones are the IFOF. Underneath you have the anterior commissure fibers, and then more underneath you have the optic radiation fibers. All these things covering the ventricle, the ventricular cavity at this point. And inner of all these fibers, deeply in all these fibers, you have these fibers that they conceptually, they do not belong to the sagittal stratum, are the tapetum fibers, And of course, to see all this, we had to remove the superior longitudinal fascicle, horizontal part, vertical part, and arcuate part. Okay, we had to remove. Of course, they don't belong to the sagittal stratum. They are much more superficial than this. And over the superior longitudinal fascicle, we have the subcortical white matter of the temporal cortex and of the inferior parietal lobule as well. So you have, of course, to understand all these layers. You have to understand all these layers. Now, what happened to... showing here. Que foi? Let's see. Oh, maybe. Não está adiantando, hein? Maybe I should turn off and turn again. Let me see if I can make it.
Tá certo.
Não, mas eu queria ter feito isso. Teria que ter recomeçado, né?
Pus para começar do meio aqui.
Okay, let's give a zoom here and see the tapetum fibers. You see beautiful dissection. These fibers have another direction and another orientation. We're not going to get into this right now, okay? But you see the splenium here. You see the splenium. This is the genu. This is rostrum. This is the body, and this is the splenium. This is optic radiation. I mean, this is thalamic radiation. This is thalamic radiation. But you see that here in the splenium, you have these posterior fibers of the corpus callosum that for some reason they go underneath and they go towards the temporal lobe. These are the fibers that we had seen in this window here when they go laterally, the tapetum fibers. See, beautiful dissection. This is the tapetum fibers. And the tapetum fibers, if you go to old and gray anatomy texts, they are described as being the splenial fibers that run underneath the optic radiation fibers. Okay? Tapetum fibers. Tapetum fibers. So let's talk now about this interesting concept that we talk a lot in neurosurgery, which is the temporal stem. It's very controversial and has a lot of definitions. And this name came with this Horel, which I think it was a radiologist, and he referred to that in coronal cuts of the brain itself, and of course of neuroimaging of it, you have this white matter of the temporal lobe, and you have just a stem here, just like a tree, you know. So he referred to this, where all these fibers get together, as being the temporal stem. You see here Dr. Penfield article, one of them, calling this all the temporal stem, okay, where the white matter of the temporal lobe gets together and gets inside, goes towards the inferior limiting sulcus of the brain. Eduardo just published with Dr. Rotten a paper about the inferior limiting sulcus of the brain. We're going to talk a little bit about this later on. But if we take this temporal stem, we see that it's all fibers that are running underneath the inferior limiting sulcus of the brain. All this area that the fibers get together and get inside the brain, here underneath the inferior limiting sulcus of the brain. But if you look better here, we have a component that it's covering the atrium, the ventricle itself, and we have another component that I call a peduncular component. If we do remove the component that would be here of white matter running along the inferior limiting sulcus of the brain, okay, which is part of this generic name of temporal stem, you will still left with this peduncle here, that it's connecting the medial aspect of the temporal lobe into the frontal base here, the basal forebrain, which is all the fibers that are within this area here. Deeply you would have the superior aspect of the amygdala going towards the globus pallidus. Of course, you have the anterior commissure, and you have the IFOF and the uncinate, everything that was already removed here. Remember that the amygdala has its superior extension then towards the globus pallidus to be incorporated in the basal brain, okay? And you see here the putamen, okay? And you see here the globus pallidus. The amygdala will be continuous here, superior with the globus pallidus. So all this part that is incorporated here belongs to this peduncular part of the temporal stem that was cutted here. See the globus pallidus here, you see here the base of the striatum of the putamen. Why did I put this? Because underneath here you would have the amygdala. The amygdala is incorporated here in the rest of the hemisphere along the globus pallidus and of course everything that it's around. Here you have the anterior perforate substance. So coming back to this, you see the sagittal stratum here. You see the uncinate fascicle. The IFOF would be here covering all this. Again, if we remove the part of sagittal stratum here, we're still left with this peduncle. And this peduncle has the uncinate and the IFOF and the upper extension of the amygdala down there. So in order to do, for example, an anatomical temporal lobectomy, you have to get inside the ventricle, open the choroidal fissure. This is a natural space. But in order to get in here, you did cut all the fibers that were coming from the roof, namely sagittal stratum, okay? And then going inside the brain along the inferior limiting sulcus of the brain. You did already cut all this. But in order to remove anatomically the temporal lobe, you still have to cut the peduncular part of it. Uncinate IFOF, upper extension of the amygdala. Okay? Again, here the amygdala going up, okay? You have to cut the peduncle. And what is inside the peduncle? Uncinate, you see the anterior commissure here. You have a real peduncle here. So the thing is that if you cut it, you do remove the temporal lobe, and of course then you would have to cut the dorsal aspect of it anterior to the vena labea as much as you need to go posteriorly. Again, to emphasize and to see from another angle how these things are incorporated. If we open the choroidal fissure, this is a natural space. We're going to be exposing the subiculum medially here, right? And medially, you have the pulvinar of the thalamus, continues with the midbrain, and this is attached like this. You see? So if we come back here, this is this space in between the subiculum and the thalamus is the lateral aspect of the ambient cistern, that it's also called the wing of the ambient cistern. The PCA would come in here, okay? And so this lateral aspect, the wing of the lateral wing of the ambient cistern has as its roof the pulvinar and as its floor the subiculum. And everything that is anterior here is incorporated. This is head of hippocampus, this is amygdala. And all this part of the brain is incorporated to the frontal base here, to the basal forebrain, most lateral aspect. Forgot to emphasize that there is a recess, a space in between the head of the hippocampus and the amygdala here inside the ventricular cavity. Let me just come back to this here. So, a great discussion is if temporal stem is all these fibers here, including the peduncle I talked about, and the sagittal stratum fibers that are going underneath the inferior limiting sulcus. If all this is temporal stem, as Horel described, as Penfield considered, okay? Or if temporal stem is just this peduncle here. There's a big Dr. Yasagil said, no, we cannot say that there is a temporal stem, because if we say a temporal stem, we have to consider a frontal stem, a parietal stem. There's no stems in the brain, okay? But, and he's right regarding this particular area here, because the sagittal stratum is just a continuation of the white matter of the whole brain. But on the other hand, this peduncle here is very specific of the temporal lobe. No other lobes have this peduncle connecting the mesial part with the frontal part, because it's just like the brain had going around the thalamus and develop these connections here. So this is very specific of the temporal, medial temporal lobe. So personally, I think that this is the real temporal stem that we should consider. But others consider everything as the temporal stem. I'm just emphasizing this because you, young neurosurgeons, are going to have all this year people talking about cutting the temporal stem and temporal stem and temporal stem. So you have to understand what the controversy is all about. So this is Eduardo's dissections at rotons to emphasize again that we are having here the central core of the brain. That's a block that has its lateral aspect, the insula, and its inner aspect, the wall of ventricular cavity with the head of the caudate and with the thalamus and the choroidal fissure going around here in between the fornix and the thalamus. The fornix then does not belong to this concept of insular block. So you see, these are all concepts to make us understand anatomy. And when people say, well, this is an insular tumor, you think about the insular block, about the central core, which is the same thing, and see what regions this tumor is infiltrating, okay? And you can see here the whole central core. You can see here the ventricular cavity, the ventricular cavity here, and this is the choroidal fissure that it's open, just getting into the ambient cistern. And this is a natural space. And then you have all this peduncle here that it's connecting the mesiotemporal lobe with the basal forebrain, which I understand that it's the real temporal stem. Eduardo's dissection, you see the anterior commissure fibers. You see here the optic radiation area. You see all the fibers here of corona radiata turn into the internal capsule. You see the tapetum here. You see it's another dissection, another brain, another fellow doing this, but it's pretty much the same. Of course, tapetum fibers having this direction here. If you remove, you can see beautiful the tapetum here, all these fibers, and you already understand everything that we talked about here. And then you lift this, you have the choroidal fissure in there. Of course, this is the pes hippocampi, the head of hippocampus. And then you have here the peduncular part of the temporal stem. Okay, let me, how much time, what time you want to finish at this point? And
looks like we have till 10:30.
how many minutes, or you think you want me to finish, or whatever? I don't want to delay.
We got another 10 if you like.
Okay, let me just finish more 10 minutes. I'll make it here. Important to emphasize that we talked about, this is the uncus, anterior half you have the amygdala, posterior half you have the head of hippocampus, and this is third nerve, this is interpeduncular fossa, mammillary body, optic nerve, optic tract. So this is important for us to come back to our anterior perforate substance, which is the wall and the floor of the ventral striatum. Just like here you know that you have the amygdala, right here you know that you have that region of the ventral striatum, okay? Septal region would be inside here. We call anterior perforate substance all this wall, this area, that it's anterior to the optic tract. Medial limit is the interhemispheric fissure. Lateral limit is the limbing of the insula. We're going to be seeing next lecture is the base, the anterior aspect of the insula, limbing of the insula. And the anterior limits of the anterior perforate substance are the olfactory stria. So optic tract, olfactory stria, limbing insula, interhemispheric fissure. These are the limits of the anterior perforate substance. Everything that is posterior to the optic tract is posterior perforate substance. Let's remember we have the mammillary body. Everything that is anterior to the mammillary body is hypothalamus. You have the tuber cinereum here. We're not seeing very well, but then you have the pituitary stalk. Neurons, axons from the tuber cinereum will be coming here to the pituitary, to the pituitary stalk, and of course the chiasm, the optic nerves here, right? And posterior to the mammillary body, you have the roof of the interpeduncular fossa. And all this area here, which is also floor of the third ventricle, of course, it's the posterior perforate substance. You see here this anterior perforate substance, and you see the anterior commissure posterior there. Posterior commissure. This is the anterior commissure. Okay, anterior commissure. And this level is the foramina Monroe. If this is foramina Monroe, you see the column of the fornix, foramina Monroe. So this is the genu of the internal capsule. And this is the area of the globus pallidus. So this anterior commissure is the posterior wall of the ventral striatum that is here. So where is this lesion? This lesion is at the base of the head of the caudate, okay? It's anterior to the anterior commissure. Let's see better. You see the anterior commissure here? What are these two things that are posterior to the anterior commissure? The fornix, because you know that the columns of the fornix are posterior here. So this lesion is anterior to the anterior commissure, okay? Anterior to the anterior commissure. And why? This is the, what is this? Head of caudate, putamen, and this is the accumbens here. So this lesion is just underneath the accumbens. We already saw that it's anterior to the anterior commissure. And why did I put the carotid bifurcation here? Because carotid bifurcation, when you see carotid bifurcation in surgery, posterior to it, you have the anterior perforate substance. Posterior perforate substance is just posterior to the carotid bifurcation, A1 and M1, okay? So what I'm trying to show is that, let's see, next slide. This lesion is anterior to the anterior commissure, is posterior to the anterior perforate substance, is just underneath the accumbens, okay? Where is this lesion? This lesion is within, is posterior to the anterior perforate substance, is within this piece of brain here, okay? is right here at the ventral striatum. That's where that lesion is. I don't know where it is. It's an incidental finding. Let's just finish with this beautiful slides here of Richard and put everything together we talked about. You see the amygdala, optic nerve. Always start from things that you know for sure. This is optic tract. So this is optic nerve, chiasm. This is optic tract. Mammillary body, okay? And then you have here the amygdala. This is ansa peduncularis. Ansa peduncularis going to the septal region, to the hypothalamus, and to the thalamus. Going underneath the accumbens. This is the accumbens. Is where the caudate would be continuous with the putamen down here. This is accumbens, ventral striatum. And what is this here? What is this? Anterior commissure. Okay, anterior commissure. Okay, let's proceed. If we see from anterior, head of the caudate, putamen, you're seeing the uncinate fascicle opening here. Okay, let's remove the uncinate fascicle, and of course we see the accumbens. This is olfactory tract. This is medial stria. This is lateral stria. Okay? What is this here? Fornix. What is this here? And you see how beautiful anterior commissure. Most of the fornix is behind the anterior commissure, but part of the fornix goes anterior to the anterior commissure. We read this all the time, but never saw such a beautiful dissection, Richard's dissection. You see, part of the fornix goes anterior. This posterior part of the fornix goes toward the mammillary body. This anterior part of the fornix goes to the septal region. Goes to the septal. You see, everything gets into this area. Goes to the septal region that here was removed. Now, the most beautiful thing here is that to see that the anterior commissure, this is olfactory nerve, olfactory tract, always resting over the optic nerve, and then you have the lateral stria, and you would have the medial stria that was sort of removed here. But you see, this is the olfactory trigone area, right? You see that the anterior commissure has this branch that goes to the olfactory nerve, the olfactory area, just as it, of course, has on the other side, just showing that this was a commissure of the very old reptiles, because they needed this. It was their corpus callosum. It was very important for them. But now it's just vestigial. It was left there throughout this million years. You know, it's unbelievable, showing what was the anterior commissure. And you can see this beautiful dissection here in this area. And coming back here, now you understand better the anterior commissure within the graciole channel with the ansa peduncularis underneath. Again, here you see the fornix with the mammillary bodies, anterior commissure, and with this beautiful olfactory branches, anterior branches here. Nievenhuis is a very good anatomy book and showed these small branches going towards the olfactory area as well. And of course, you have the corpus callosum with the transverse fibers superior there. And we come back here, and I'm not going to get into these vessels right now. Okay. Otherwise, we won't stop here, you know. Anatomy, you know, it doesn't end, because when it ends, you have to come back and forth and start everything again. But let's proceed with the other lectures, and if there's any questions, I'll be glad to answer. Try.